Queridos participantes do Fórum Alianza Latina, em setembro, a Abralha organizou a 7ª edição do Congresso Todos Juntos contra o Câncer, importante movimento conduzido no Brasil para o enfrentamento do câncer. Durante este congresso, foram apresentados diferentes conteúdos que contaram com a participação de especialistas de distintos setores relacionados à saúde. Iremos compartilhar parte deste rico evento, trazendo nesta sessão do Fórum Alianza Latina o debate sobre tendências no mundo pós-Covid. Neste painel, os renomados convidados apresentarão tendências no mundo sobre os aprendizados para a saúde com a pandemia, a importância do empoderamento dos pacientes nas pesquisas clínicas e a universalidade como premissa no atendimento a pacientes da comunidade LGBTQ+. Espero que aproveitem o evento.
My name is Kerry Adams and I'm the CEO of the Union for International Cancer Control based here in Geneva, Switzerland. And I'd like to say thank you to the organisers for giving me a platform to talk about global cancer control during the time of the COVID pandemic and crisis. It has indeed been a very challenging few months for the world, challenging for people like myself and our families, our friends, our colleagues, but also for the cancer community and particularly patients. I've been asked to talk for about 10 minutes on what I think have been the consequences of COVID on cancer control globally. And I'd like to break down my commentary into 4 areas. The first area, I'll talk about what we've learned about the issue of prevention as a community around the world, given that prevention is so important to avoid cancer in our lives. I'll then talk about the treatment and care challenges we've had during COVID and what learning points we have for the future. Thirdly, I'd like to talk about the way in which governments have responded to the COVID crisis and what we can learn from that response and a whole of society response to cancer control and other non-communicable diseases in the future. And finally, I'd like to talk about global governance and what this all means for global governance of health issues and the role of the World Health Organization, which is just around the corner here in Geneva. So let me start by talking about the masterclass of prevention, which we have experienced as a community over the last 4 or 5 months. The fact that we all are wearing masks, the fact that we've been encouraged to distance from each other, the fact that I'm sitting in an office in UICC in Geneva and we have distancing protocols around the office, and if you walk around you have to wear a mask. The fact that many organizations now work remotely. If you go into a shop, you have to wear a mask and they're regularly cleaning your hands. This is the first time really as a global community that we've faced up to a disease and we've had to respond in a very positive way to restrict that disease going around to friends and family and partners in the society that we live in. Prevention has become the buzzword. We have to stop the pandemic going around the world. Well, it's no different really to cancer control. You know, we have to address the risk factors of tobacco use, of alcohol use, of obesity, poor food and diet, vaccinations for young girls for HPV. So we've had a masterclass of preventing a disease. And my belief is that in time, that will move over to the prevention of NCDs and also cancer. That we will become more conscious of the fact that obesity does lead to poorer outcomes for COVID, and obesity does lead to more chance of having cancer. We have learned that those who smoke have a greater chance of having a poor outcome through COVID, and exactly the same is when it comes to cancer and the other NCDs. So I'm hopeful that our generation will be the first generation that really understands the power of prevention when we're addressing diseases globally, and cancer is a global disease. Let me move on to the second area, which I think is really important. That's treatment and care. I have been absolutely astonished and amazed by the UICC members around the world, maybe 1,200, many of whom are patient groups, who have re-engineered their business model to deliver services and support to patient groups, to patients around the world, deploying the use of Zoom, as we're doing now, using webinars, using telephone call centers, whatever it may be, to make sure that the patients who are currently seeking treatment and also facing the chances of developing COVID are supported through their journey. It's been astonishing. We've been running dialogues and webinars at UICC, which has given people the opportunity to talk about how they have changed the way they've reached out to a community which is definitely in stress. Now, I think there's been some learning there. We've learned that we can do a lot remotely, which we didn't know before. And some of the old models of face-to-face support have been changed. And I think they will continue, not just in supporting patients, but the way that we actually share information around the world, the way we put education and training into, for example, the UICC membership. I can't see conferences and congresses taking place face-to-face for many, many months in the future. But what we are seeing is that virtual alternatives supporting people in the cancer community are working. The numbers of people who dial in is big. It's much larger in some instances than previous congresses. So I think there's a lot of opportunity in the future on how we support patients through their journey, but also how we train, educate, support, and share best practice. So from a UIC perspective, having re-engineered our business model to become virtual and supporting our organizations around the world, I believe we will end up in a position where we can improve cancer control globally. The speed of sharing information, of best practice, of encouraging dialogue, encouraging people to work together is something which has been accelerated through the COVID crisis. And I'm optimistic the outcome will be a cancer community more connected than ever before. However, the financial crisis coming out of COVID is appalling. We've recently conducted a survey of UIC members around the world, and that's showing that whichever country you go into, the lack of funding is making it very difficult for cancer organizations and patient groups to support their communities. I don't know how long this will go on. It could be 18, 24, 36 months, but I suspect that the shadow of COVID on the cancer community with regard to funding will be a lot longer than the actual pandemic. We need to survive. So we need to be innovative. And I go back to what I've just said, we need to share great ideas, practices to help cancer organizations see their way through the financial crisis of the COVID crisis. And that's one of the focus areas that UICC will be spending time on in the next 12 to 18 months. Let me go on to the government response to COVID, and I won't go make any political commentary about how one government has responded in a different way to another government and whether that has led to larger numbers of COVID cases than actually should have happened. But I will talk about the fact that for the first time, we've seen a disease leap out of the health department of a government and embrace every aspect of government control. So we've seen it, it's got economic impacts, financial impacts, it's got education, schooling, trade, and the economic consequences have brought governments together to address a disease as a government, with the head of state taking a lead role in guiding the country through the crisis. Why is this important? I remember in 2011, when we were at the UN high-level meeting on non-communicable diseases, that we managed to get embedded in that document that came out of that meeting, a commitment to a whole of government approach to NCDs. And I'll be honest, it's been difficult to see major evidence of that over the last 10 years. The cancer issue, the NCD issue has stayed firmly within the health department and the health minister's area. And yes, it has occasionally come out, and some countries have done brilliantly in developing national cancer control plans, which do embrace the full continuum of cancer control and bring in the other elements of governments to make sure that things can change. Now we have seen a health issue where it has to be addressed by the whole of government. And my belief is, because they've seen a health issue which has impacted economies, impacted education, impacted the trade of that particular country, even the PR, the way the government is perceived around the world, and potentially governments could be thrown out if they do not behave in the appropriate way to address COVID over the next few months. We have a government ready and primed to understand the consequences of health on society. And I believe there's an opportunity to push harder for all aspects of government to look at and to take an interest in cancer control, whether that's prevention, early detection, treatment, or care. So there's an immediate benefit, which I think the cancer community can build on in future years. The fact that we've had a really good example of where we pull together a government to address a health issue and we can have an impact. Let me move on to the fourth area, which I think is quite important. That's the issue of global governance. And we have had questions asked about the role of WHO with regard to COVID. I am not a specialist in the COVID pandemic, and it's not for me to comment on the strengths and weaknesses of the response from WHO. I will say that given that we have uncovered every government and every part of society has struggled to understand the pandemic, it's not surprising that even WHO has had to learn as it's gone along. And yes, the changes in recommendations have probably reflected the emerging research which has come out as the COVID pandemic has spread around the world. But nonetheless, it is quite wrong to position WHO as just being the COVID organization. They are not. They do amazing things for non-communicable diseases. They've got a terrific team in there. They do incredible work on, for example, tobacco control. They've got teams that are looking at the prevention of NCDs all the time, producing guidelines, advice, and support for member states around the world. And they also have a great team on cancer, which over the last few years has diligently delivered a cancer resolution. They've improved the essential medicines list for cancer and essential technologies list for cancer. And now they're working on cost-benefit analysis to advise member states on how to invest appropriately to address the cancer burden they face in future years. WHO's role in NCDs and in cancer control is absolutely essential. And whilst there may be some larger countries with on the high income level who probably do not take as much advice from WHO as others, I can guarantee the advice given out by WHO to low and middle income countries becomes an essential part of the way that they address cancer and NCDs in their country. So for me, the role of WHO is going to be reinforced through this. I believe we'll get through the other side and see a reinvigorated role for control of diseases centrally, and there is no alternative to a WHO. And therefore, the role of UICC and its members working with member states and WHO is absolutely paramount. We have to support them through the crisis. We have to accept at the moment that their time, energy, and focus is diverted to the pandemic, but recognize that it will come back to cancer again, and we as a community have to respond. We have to take our learning to help WHO and WHO to inform and guide us on best practice. And that's a role that I think UICC and its members can play in future years. I think the one problem that we have with that is whether there's going to be a massive cancer community left after the financial crisis. And I can assure you from a UIC perspective that we will do everything we can possibly to ensure that we as a community thrive post the economic consequences of the COVID crisis. So in summary, where do I think we are? I think the UICC members around the world have done brilliantly supporting cancer patients through the journey whilst we've had COVID. I have great admiration for all of those who have put their own lives at risk in order to support others to make sure they get the treatment that they require. And I really am very, very supportive of all those individuals who've worked in the health sector during this crisis and have supported patients through their cancer treatment and care. I think the patient groups have adapted their way of delivering services to patients through that journey, and we should admire the way in which they've adopted new technology to make sure they can reach into the lives of people who have cancer and their families to support them. And I can see that continuing. I see governments responding to a health issue like they've never done before, not certainly during my lifetime. And I hope that that is a continuation right through the next few years, where we see more investment in universal health coverage, more investment in health infrastructure, more investment in prevention. And the early signs are that people are becoming aware of the issues of obesity and smoking, not just on COVID, but on cancer and the other NCDs. So I'm optimistic we can move on that when we get through the COVID pandemic. And finally, I think that the UIC community will grow and it will continue to have an impact on society. So thank you very much to all of those people who are part of the UIC community. I think you do a tremendous job, and I'm very proud to represent you in Geneva, talking to WHO and the other health leaders here to say what we're doing to help us through the pandemic and make sure that the cancer community is protected and thrives after that. Thank you very much.
Thank you again for the opportunity to present in this very important Congress, and I appreciate the comments made by the co-panelists about the importance of having a holistic approach in this current pandemic, and also the video message that love is really a driver, but where can we find that love And what is the role of the system, the health system, to enable our cancer patients to feel that their needs are being met, with them at the center of their care? This pandemic has uprooted our understanding of how to provide this idea of integrated people-centered care. So what can we learn? What response is needed? This is what I will be focusing on for the next 15 or 20 minutes. To briefly start, I have no conflicts of interest to disclose, and I'm an employee of the World Health Organization, and thank, of course, the organizers for this unique opportunity. As we heard, it is important to think of the response to the pandemic in two ways. How can we understand the problem? Because if we are going to come with a solution, we have to have a shared understanding of what, in fact, are the underlying problems. The second part will focus on the solutions. Now we have information. As we rightly heard from Dr. Enrique and Dr. Philip, we were in a moment where information was absent. We didn't know what this pandemic would bring, but this has changed. So what can we do? What strategies exist to address this current pandemic and to offer cancer care to everyone, that is, even in spite of the threats of the pandemic? So let us begin. Many of us have clinical backgrounds. I'm also a cancer surgeon, and this is how I see the experience of caring for a cancer patient or family. They come in with symptoms, and my goal is to make them a survivor. There is a step, a process, the cancer pathway, that we think about to ensure that all their needs are met. But there's a surrounding system, and the function of the system is to ensure that everything is there at every step of the process for that patient and for their family. Do we have the right workforce? Do we have the right medicines? Do we have the right hospital care, accreditation, regulatory oversight? This is the broader concept of the health system. And how can we create and enable our health systems so that cancer patients receive the best possible care regardless of circumstance and regardless of time? We know going into this pandemic, we are already behind. We have made tremendous progress in cancer. There is no doubt of that. But there are still great global inequalities, and there is also significant progress that needs to be made. When we look at the system around the world, we see that there are major gaps. Late diagnosis, very common. Inadequate workforce. In poorer countries, we see that there is one oncologist for every 1,500 cancer patients. This makes it impossible to provide high quality care. We see that many countries lack a regulatory oversight process for ensuring that cancer care is of the highest quality. Data systems are weak, medicines are absent, patients are paying out of pocket, the list goes on. So when we look at that cancer pathway, in fact, we see already problems with late diagnosis, inaccessible care, low quality, and inability to enable our cancer patients to return to their homes, their community, and to the workforce. Here are some statistics to reinforce that. But what has been even more concerning is this. We all sustained a shock. This year of unprecedented global pandemic. And now in the presence of this shock, we ask ourselves, what can we do to respond now and to build back better? Where does cancer fit as an essential health service, and how does it fit in the broader community and economic, socio-political agenda? So here we go. The idea is to break it down to the root. What is the underlying problem? We know that there is an issue. In fact, when you look at Google searches for cancer and COVID, it is one of the most common. We see stories around the world of people fearful, cancer medicines not available, cancer diagnostics delayed. So we have to ask ourselves why. There are in fact multiple reasons when we look at the cancer pathway. Why are there delays? Well, we see many people are having fear of going to their primary care provider. Diagnostic services not available. If you have one radiation oncologist in your hospital, one medical physicist, that person becomes ill or is in quarantine. What then becomes of the service? What has happened now, we're increasingly seeing that cancer medicines are at risk for being at a global shortage or stock out in hospitals. And as we rightly heard, how can we protect our patients? We know that cancer patients are at higher risk of a death from COVID. But how do we protect them? What types of interventions are needed? These are the underlying problems. And here again, we see some initial statistics. Cancer diagnoses down 60%, meaning we're expecting a wave of new cancer patients as we hope and anticipate the pandemic will resolve. But in the interim, we know that the cancer patients will be suffering worse outcomes because of it. Treatment alterations are shifting. People are unable to access best standard of care anymore. We want to share with you one systematic review that we've just completed, and with special thanks to our Brazilian colleagues, because we have noted with great appreciation the influence, the commitment, and the passion in the Brazilian cancer community. So with support from Hospital Sírio-Libanês and from the Oxford Brazil EBM Alliance, we've completed 2 systematic reviews looking at the delays in cancer care and the interruptions in cancer care because of COVID. With the recognition that there is much to say on this topic, I will share with you some of the key findings. One, it reinforced our realization that cancer care is being disrupted everywhere in the cancer pathway and for every type of cancer service, from diagnostics to systemic therapy, surgery, palliative care. Unfortunately, we don't know what all of this means because sometimes a delay is acceptable and sometimes it's not. So we know that some of these delays were organized and intended, but for those that are not, we don't yet know what will the outcome be for increased deaths during this period. We also have noted that the broader context of the pandemic is influencing cancer outcomes as to be expected. People unable to access public transportation, get to a doctor, speak with a nurse. This is having serious consequences. And then the final point is there is more research that we need to do to understand what is the root problem. Nonetheless, we have to come with solutions now. So from those root causes, we can start looking at what are the responses that we as a community can conceptualize by identifying these causal factors and thinking what are the effective solutions. So now let's get into that. Because unfortunately, as we think about it, the solutions to date have yet been well articulated. There are some, and what I will share with you is the early evidence from what we have seen be successful. But there's a lot more we can do. We start with the recognition that a response has to be tailored to the local context. We all know this, but it is important to say because it is very different for a country that is experiencing community transmission compared to a country that is at a different phase of the pandemic. We also know that the response has to be multi-sectoral. This can't be governments in isolation, this can't be communities, but it requires everyone. Governments, communities, academia, industry, everyone has to be at the table for us to realize the best potential to mitigate the effect of COVID on cancer. And finally, the importance of measuring data, because this will help us understand if our strategies are making a difference. At the center of all these preconditions are people, as we heard. People providers, people managers, people are patients. And we must remain committed to our cancer workforce. Because when we think of who's at the front line, who's at greatest risk, and who needs the greatest support, it is our patients and it is our providers. Because without it, no mitigation strategy will be effective. So then we think, what system changes can we make? How can we create a system that allows cancer patients to have the best opportunity to complete their therapy? And what we see are these 3 general approaches. First, within the cancer community, we have to task ourselves, and this is an important topic for debate. What are certain things that we're willing to accept are delayed or postponed? There have to be some. There have to be some services we say must be given tomorrow, and some that we can tell our patients, well, are recognizing the risk, we can consider postponing it for 6 months, 12 months, etc. But we as a community have to come together with that consensus. If not, we will lose our ability to communicate that list of essential services. Number 2, the importance of communication. Our role is to ensure that people who are fearful of cancer, that have cancer symptoms, that have a cancer diagnosis, or are just interested in cancer, understand what does this pandemic mean for cancer? Are they at higher risk? If so, what is that relative risk? Are there services that are available? How can we enable those services? It is important that we get to the grassroots, and as we'll describe, mitigation strategies that focus at community level engagement are the ones that we have found to be the most successful. And finally, to think about how can we create a workforce model that's adaptable, that recognizes that we may be stressed because a certain workforce group would be unavailable, or that the necessary infrastructure isn't there to support them. To go briefly through those three as we wind down the talk. The first, again, is to think about what is a core service. In that regard, we're very pleased to share with you that the WHO office in the Americas, known as PAHO, has produced a list of guidance to say for governments, for stakeholders, think about these as the highest priority. If we can get these cancer treatments initiated, then we will allow for the population outcomes to be maximized, recognizing that some can be delayed and treated at an interval. How do we develop those adaptive treatment regimens or strategies? And that's something, again, the scientific community can come together behind, and we have seen multiple professional societies develop such guidance. And how can we reevaluate those recommendations over time? The second, again, is to ensure robust communication. There has been a high number of media publications saying cancer is going to be threatened during this pandemic. Be scared. There are reasons to be conscientious, but we as a community cannot drive our progress through fear. What are the necessary messages to reassure our patients, to reassure our community? And this is why community engagement is so essential. And then finally, what can we do to enable better coverage of services, whether that means increased use of telemedicine, adapting roles so that different types of providers can do home visits, patient flows being revisited, home care being optimized, and medication access being addressed. We've seen these done in country, we've seen progress because of these strategies. But this is a big step because all of us within the cancer community can come together. So we don't see one hospital using one approach and a different hospital using another. But how can we do it in a more coordinated way to ensure consistency for a country and for a region? There will be challenges as we talk about these topics, and this is why a debate is so appropriate in this setting. As I mentioned, we don't have good enough data to say with confidence this is the best approach. In the systematic review looking at mitigation strategies, we found only 9 published studies. So we are all recommending what we think is best based on our scientific intuition, but not necessarily based on data. And this is the challenge for all of us as we look to the next phase of this pandemic. The second is we realize again that this pandemic has exposed some of our greatest vulnerabilities. We see resources in cancer money being diverted away from cancer, whether it's in the hospital setting, whether it's in industry, whether it's in research and innovation. And we also see many of our civil society partners being threatened because of this pandemic, their funding being taken from underneath them and no longer able to provide the services and functions that they do. How can we empower civil society and ensure that these non-governmental organizations remain a very rich part of the cancer landscape? And then finally, how can we think about addressing this pandemic of misinformation? How can we use science and push that some interventions are in fact science-driven, and those are the ones that should be prioritized? If we do that, then we can have success. Countries have developed resilience strategies. They've developed preparedness plans for this pandemic and for others. It's important that we think, how can cancer be included in that? We have reviewed countries' preparedness plan for pandemics, and unfortunately, many of them lack any specificity on cancer. So not only speaking in the scientific community, but we have to knock on the door of governments to say, this is what we were asking you to do in this current pandemic, and should any future threat arise. Again, what are our essential services? What are we going to prioritize? And this is not a simple question to ask. But that we should remain positive. Risks can be mitigated, outcomes can still be near optimized or maintained, but it will require all of us come together to use our best approaches, the best possible science, and the goodwill of knowing that if we do this together, we can in fact make a major difference. Thank you again for this opportunity, and I look forward to our continued discussion.
Hello, everyone. Thank you very much for the kind invitation to speak at this Brazilian Congress. And it's my huge pleasure and honor to be speaking about some important aspects regarding cancer clinical trials that all patients and advocates of cancer should be aware of. I'm Dr. Vishal Kewali. I'm an assistant professor at Queen's University, Kingston, Canada. I have no conflicts of interest to disclose. So the first thing is about the importance of clinical trials. We always see this sentence being told again and again that clinical trials are always the best option for patients. That's absolutely true. But there is an important caveat to that. Not all clinical trials are patient-centric and well-designed. So participating in a clinical trial that is not patient-centric and well-designed is not a good idea. So clinical trials are always the best option for patients, should be taken with a grain of salt. Only well-designed patient-centric clinical trials are worth participating in. Only well-designed and patient-centric clinical trials are the best option. So what do I mean by that? That means all clinical trials do not necessarily solve the patient agenda. For example, a trial that is designed from the outset to test clinically irrelevant marginal differences. I'll give you an example. This paper from Lancet Oncology in 2016 was testing a drug for advanced ovarian cancer versus placebo, and the conclusion was this drug significantly increased progression-free survival. So when you read this sentence, the drug significantly increased progression-free survival, you would assume that there must be some substantial improvement. But actually, if you read the results, then there was an improvement of only 18, not months, but days. Just 18 days, and this is not even survival. This is a surrogate endpoint. But it is statistically significant. The p-value is less than 0.05, so this sentence is not wrong, but it is quite meaningless, an improvement of 18 days. So how did this such a small difference of 18 days become significant? Because this trial recruited more than 1,350 patients, a huge number of patients. If you recruit a huge number of patients, then all small differences can look significant. So that means this trial was designed from the outset to detect such a small difference as significant. That means there was no confidence in the efficacy of this drug to begin with. So there would be no point for a patient to participate in a trial that was designed to detect such a small difference as significant. If you want to read more about this particular trial, then I recommend you to read this paper that I saw at the bottom of the slide. This is an open access paper. So let's continue with the examples of clinical trials that don't solve patient agenda. The other is a trial that ignores patient-related outcomes or quality of life. We had done this study in 2018, in which we looked at 352 phase 3 randomized trials for advanced cancer, and we found that 50% of them, they did not even include quality of life as an endpoint. And of those that did, 25% did not report pre-specified quality of life endpoint. So this means a trial is being done for a drug and patients are recruited, but they are not collecting the information on how the patients feel while on the drug. If it is a good drug, then the patients are supposed to feel better after taking the drug. But if you are asked to enroll onto a trial and there is no plan to collect quality of life data, or there is no plan to publish quality of life data, then you should take that with some suspicion. Altogether, in these trials, we found that there were 125,000 patients whose quality of life outcomes we do not know. So this is a huge waste of patient resources. And patients, they always tell us that one of the reasons why they enroll into trial is to help science and to help future patients from the knowledge that comes out of this trial. But if we are not collecting this information, this is not going to help anyone. The other example is a trial that is conducted without rationale. Now, what do I mean by that? We looked at a number of negative phase 3 trials, trials that failed, phase 3 trials that failed. And we found that actually more than 40% of these negative phase 3 trials were conducted without a supporting phase 2. Now, usually a drug is tested in phase 1, phase 2, and phase 3. So we found that 40% of the trials that failed in phase 3 actually did not have any a supporting phase 2. And 14% of these actually had a negative phase 2. Now, this is quite mind-boggling. A drug failed in a phase 2 but still was tested in a phase 3 and it became negative in a phase 3. Now, there is no benefit for patients in participating in a trial that ultimately failed because that drug did not show benefit. Now, again, there is always a chance that the drug may not work and the trial may be negative. But if we know from the beginning that the drug has already failed in a phase 2 trial, then the chances that the drug will fail in a phase 3 is pretty high because it has already failed before in a phase 2. So if you are participating in a phase 3 trial, you should, as a patient, you should always be asking for the phase 2 data. You should ask whether the drug was already tested in a phase 2 and whether it was proven to be effective in a phase 2. The other example is a trial that uses non-inferiority design inappropriately. For example, in liver cancer, there was a new drug called lenvatinib that was tested against the standard of care sorafenib. And sorafenib is an oral drug. It has some side effects. Lenvatinib is also an oral drug and it also has a number of side effects. So there was no point in testing this drug in a non-inferiority design, and in fact lenvatinib is much more expensive than sorafenib. In a non-inferiority trial, what we are asking is whether this new drug is not worse than the drug that we already have. Now, that might sound crazy. Why would someone want to test a new drug if it is as whether or not it is worse than the drug that we already have? Because we need drugs that are better than what we already have. But non-inferiority does make sense in a couple of conditions. If the new drug is cheaper, if the new drug is less invasive, like oral versus injection, and if the new drug is given, let's say, once every month instead of once every week, or if the new drug has a better quality of life, it does make sense. However, in this particular incident, there was no such benefit, and still the drug was tested in a non-inferiority design. And the other example is of a trial that uses inappropriate crossover and a trial that uses a substandard control arm. What do I mean by these things? Please allow me to. Crossover means whether or not the patients in the control arm will receive the drug in the experimental arm when they progress. Now, sometimes this is rational and should be done. Sometimes this is irrational and should not be done. For example, this drug abiraterone, it was already approved for castration-resistant prostate cancer. It was already approved. It showed improved survival. And in this trial, we tested whether the same drug was effective in castration-sensitive in earlier course of treatment. But what happened was, after the disease progression, patients who were getting placebo in this trial, they should have received abiraterone because abiraterone was already approved. So they should have received the drug when they progressed. But we saw that only 11% of the patients who got placebo actually received abiraterone when they progressed. So that means the survival difference that we are seeing in this trial could simply be because the patients in the control arm, they did not get an effective drug when they progressed. In another example, again from prostate cancer, this was a trial of Sipuleucel T, a vaccine. We saw that patients in the placebo arm, they went on to receive this vaccine when they progressed, when in fact these vaccines had never been approved before. So we didn't know that they were effective. In that case, when these patients in the control arm, they progress, they should have received an effective treatment that has already been approved, like docetaxel, which is quite effective. But they went on to receive something else and they lost time in getting this unproven treatment. And that's why we see that this drug actually has only one response. There is no effect on tumor progression. but it improved overall survival. And this could simply be because the patients in the control arm, they were denied an effective treatment for a long time. So this Everatron example is an example of a crossover that should have happened but did not happen. And Sipuleucel T is an example of a crossover that should not have happened but happened. And we also talked about substandard control arm. Whenever you are participating in the trial, there is an experimental arm and there is a control arm. And you could be randomized to any of these arms. So you should always ask what the control arm treatment would be, because sometimes the trial could be using an inferior control arm in order to show the experimental drug as effective when it is not so. And that can happen in two ways. One, they could be using a control arm treatment that is already known to be inferior to another treatment, or they could use a placebo when an active treatment option is the standard of care. For example, in case of ASCEND-4 trial for ALK positive non-small cell lung cancer, ceritinib was compared against platinum chemo, when in fact crizotinib had already received approval for ALK positive first-line lung cancer. It had received approval in 2011 and full approval in 2013. But this trial ran from 2013 to 2015 when we already knew crizotinib was effective, and patients, if they were not a part of the trial, they would have received crizotinib. But because they were a part of the trial, they got platinum chemo, which we already knew was worse than crizotinib. The other example of using a placebo inappropriately, patients with metastatic pancreatic cancer, they get chemotherapy like FOLFIRINOX. And if they respond to chemotherapy, we continue chemotherapy because this is quite a lethal cancer. But in this particular trial of olaparib, patients in the control arm, they were stopped on the chemo after 16 weeks and they just went on to receive placebo. So these patients got placebo when they should have received active chemotherapy in the control arm. So we discussed about various issues, but what can we do? So I think the most important policy change is that we need to get patients more involved. We need patient empowerment and patient involvement for every aspect of trial design and launch and conduct and result dissemination. The patients should be at the center. We talked about non-inferiority design trials earlier. We looked at all the non-inferiority design of design trials for cancer drugs, and we saw that the non-inferiority design was not appropriate in 40% of them. And the definition of non-inferiority was up to 1.33. That means here is the non-inferiority definition for these trials. That means up to 33% increase in the risk of dying was considered to be not worse. It was considered to be acceptable. But there is no basis for that. Like the trialists or nobody asked the patients up to what margin of non-inferiority is acceptable. Did the patients actually consider up to 33% increase in the risk of mortality as acceptable? No, we do not know. So we have to ask patients' opinion in deciding such things. You know, whenever you read a clinical trial report, the side effects are reported in such a way. The toxicities of the cancer drugs are considered to be acceptable. But acceptable to whom? We have never asked patients whether the side effect was acceptable or not. Chronic diarrhea, going to bathroom 10 times a day for 5 months, and the trial report says the toxicity profile is favorable. It was well tolerated. But we have not asked the patients. Only the patients can decide what is acceptable or tolerable side effect. So we need to get patient input every aspect, and we need to educate the patient as well. We just talked about placebo control arm. Sometimes the placebo arm is justified. Sometimes the placebo arm is not justified. So we need to teach the patients about these concepts, about double-blind study, placebo arms, and things like that. And some of the patients get surprised with financial toxicity of clinical trials because, whenever we talk about clinical trials, we say that the drug is for free, but the drug is not the only thing. There might be other hidden costs that the patient is not aware of. So I guess I have summarized a couple of key questions that the patient should be asking before getting enrolled in a clinical trial in order to ensure that the clinical trial is patient-centric. And here is a list of the questions that I think you can take a note of and you can consider before enrolling into the trial. You should be asking about the control arm, what is the standard of care? If you are not a part of the trial, what is the treatment that you receive, and is that still a part of the trial? And is doing nothing an option? Active surveillance for a number of cancers? What phase of the clinical trial it is? What is the hypothesis? Is it a randomized trial? Is it a are you testing whether the drug is not worse, or are you testing whether the drug is better? What are the side effects? What is the effect on quality of life? What is the other extra burden I need to face? And whether or not you are going to publish this. So this is my final word. We need to always keep in mind that trials are there to solve patients. It's not the other way around. Thank you very much. It has been a pleasure, and I'm happy to answer your questions by email or other methods. Thank you.
My name is Juno Obedin-Maliver, and I use she and her pronouns, and I'm an assistant professor of obstetrics and gynecology at Stanford University in California in the United States. As was mentioned, I'm also the co-director of the PRIDE study, a prospective longitudinal cohort of sexual and gender minority people. Thank you so much to the organizers for the honor and privilege of speaking with you today. I do have some disclosures, although this field isn't very lucrative. I have some grants that support my work as shown here, and I'm involved in some ongoing consultation unrelated to topics noted here. My objectives for today are to help you understand some key language about working with LGBTQ plus people, understand the risk factors for poor LGBTQ plus health outcomes, including and specifically related to cancer, and understand some immediate next steps you can take in your clinical practice or research to support LGBTQ plus people. Now, first, in delving into this topic, it's important that we take a moment to define who we are talking about. Many of you may be familiar with the acronym LGBT or LGBTQ or LGBTQ plus to mean lesbian, gay, bisexual, transgender, and sometimes queer. Sexual and or gender minority is a newer term used in medicine and public health to represent people who are not straight, that is heterosexual, or not cisgender. Cisgender people, for those who might have taken organic chemistry in the past, refers to people for whom their gender identity is consistent with their sex assigned at birth and uses the prefix cis, meaning on this side of. In other words, people who are not transgender. That's the majority, but not all of the population. For some percentage of the population, identify or have the experience of being transgender, which is often an umbrella term for somebody whose current gender identity differs from their sex assigned at birth. It's also to connote a gender outside of the man-woman binary, having no gender or multiple genders. And it's important not to use the term transsexual, female to male, and male to female. At least in English, these terms are really falling out of favor, though I recognize that these terms may mean different things in different languages and cultural contexts. I use sexual and gender minority, or SGM, and LGBTQ plus interchangeably. Now, little is known actually about the sexual and gender minority or LGBTQ plus population around the world. Since this conference is based in Latin America, I wanted to mention that countries in Latin America are very mixed with respect to rights and visibility for LGBTQ plus people. Many profound and positive changes in Latin America and the Caribbean recently, but there's still many challenges. In several countries, for example, same-sex marriage is legal, and sexual orientation and or gender identity are included as protected categories in some domestic anti-discrimination laws. But advances have also produced much backlash, and in some settings, increased violence and discrimination. And little is really known about health and cancer. And that's because there's really a failure systematically to collect information about sexual orientation and gender identity data. And these data lead to invisibility in health and healthcare needs. And in many countries, unfortunately, being LGBTQ plus is still considered a crime. and in some, a capital offense. This map here shows some of the differences by country, a little small here, but you can see the link, and I encourage you to look at the organization Outright International to get a better understanding of how LGBTQ-related laws differ around the world. What we do know is that around the world, 83% of those people who identify as lesbian, gay, or bisexual keep their orientation hidden from all or most of the people in their lives. And concealment results from fear, and concealment results in a lack of knowledge, and also concealment results in poor health. Now, I am based in the United States, and we do have a little bit of data, although we are also very much lacking in understanding. And in the United States, we know that there's a real problem of invisibility, and that approximately 4.5% of the general population, or 20 million individuals, identify as LGBTQ. And that's important because some of you may be even wondering, why are we focusing on this topic? How large is the LGBTQ plus population? The most accurate answer is that we actually don't know, because sexual orientation and gender identity, as distinct from sex assigned at birth, are not captured on the US National Census or many countries, as I just mentioned. When we estimate the LGBTQ population in the United States, we understand that LGBTQ plus people make up at least 4.5% of the population. And I say at least because we know that that is probably an underestimate. We also know that there are differences according to generational cohorts of how people are identifying. We think that this is not due to a difference in inherent population prevalence, but comfort with disclosing identities, which is why the millennial line in the green, approximately 8.2% of people identifying as LGBT. The takeaway is that at least 4.5% of people, or roughly 20 million adults in the United States, are LGBT. So SGM people are of all age groups. Also, this research shows that SGM people are across all races and ethnicities, and in all regions of the United States. We also know around the world there are LGBT people in every country and every region. Now, because it was recognized that the population of LGBT people is large and growing, in 2011, at the behest of the National Institutes of Health of the United States, the Institute of Medicine, now called the National Academies of Science, conducted a report on the health of LGBTQ people and concluded the following: that the relative lack of population-based data presents the greatest challenge to describing the health status and health-related needs of LGBT people. Because sexual orientation, though, and gender identity are still not collected, we fail to really understand the correlation between being a sexual or gender minority person and important health outcomes such as cancer. And we see this in the absence of data in one of our major tracking programs for understanding cancer data, the SEER, or Surveillance Epidemiology and End Results Program, which does not comprehensively collect sexual orientation, gender identity, and sex assigned at birth data. What we do know, although comprehensive data are limited, particularly in cancer, we know that there are significant health disparities among those who are lesbian, gay, and bisexual compared to those who are straight and or cisgender. This study, using the Behavioral Risk Factor Surveillance Survey data of older adults, shown here in the blue, that LGBT people, almost on every indicator of health studied, from poor physical health to obesity, diabetes, LGBT people fared worse than their straight counterparts. We know too that cancer prevention cancer is often tied to a failure of prevention, although not exclusively. And we know that public health, primary, secondary, and tertiary preventative health measures are often missing the mark at really involving LGBTQ people, or including them in visible ways that really speak to these communities. Take, for example, guidance from the ASCCP that talks about systems failures that lead to cervical cancer. This is important to recognize the role of systems in leading to a cervical cancer diagnosis. It begins by noting that healthcare providers do not screen, quote unquote, women, and women do not come in for screening. But these statements invisibilize the experience of people of other genders. For example, transgender men who have until very recently been entirely invisible in efforts to prevent cervical cancer, necessitating targeted public health campaigns such as Check It Out Guys campaign in Ontario, Canada. As a reminder, transgender men are individuals who identify and live as men in their lives, but were assigned female sex at birth, and so many of them still have a cervix and uterus, and of course need cervical cancer screening, and unfortunately have a risk for developing cervical cancer. Now, despite large gaps in data that I've already discussed a number of times, there are significant risk factors and health differences experienced by LGBTQ people that can lead to the development of cancer or worse cancer outcomes. For example, we see higher depression, anxiety, suicidality, higher smoking and substance use, lower parity, less breastfeeding, less birth control use, and lower socioeconomic status, more joblessness, more homelessness, and lower likelihood to see a healthcare provider or have a primary care provider. But what about cancer? Well, there are paltry data, as I've mentioned before, because of the absence of routine data collection. But we estimate that at least 84,000 incident cancer cases and 30,000 deaths per year in the United States among LGBT people. And we really have a sense that there are differential cancer rates and pre-cancer rates. As indicated by some of the risk factors discussed, LGBT people may be a greater likelihood of having cancer or delayed presentation to care. This, however, is not thought to be genetic or related to inborn risk, but rather comes from stigma and discrimination at every turn that keeps people staying away from healthcare settings. We call this minority stress of living in a world that at every turn penalizes you for who you are. Additionally, there were directed advertising and directed focus on exacerbating poor risk health factors such as smoking, like tobacco companies that particularly targeted LGBT people, such as this one, which was called Project Scum, targeted to LGBT people. Scum stood for Subculture Urban Marketing. Another systems issue that contributes to poor health and cancer outcomes is the consistent finding that gender minorities have negative experiences in healthcare due to stigma. These data from the 2015 U.S. Transgender Survey of over 27,000 people, we see on the left that 33% of surveyed gender minorities reported one or more negative experiences with health providers in the last year. And on your right, nearly a quarter of those surveyed reported that they did not see a healthcare provider because of fear of discrimination and mistreatment. So, although we train our students and health providers in some ways well, we train them poorly in others. And although prior research has shown that people can follow, for example, health cancer guidelines, they often don't know how to take care of individuals, LGBT individuals, and may balk at taking care of, for example, a man like Robert Eads, a transgender man who succumbed to ovarian cancer after being turned away by almost a dozen clinicians. It's not only, for example, that we follow guidelines, but we must ensure the guidelines actually reflect the diversity of our communities and that we can customize those guidelines to care for all people. For example, in looking at NCCN guidelines, much as what I mentioned with the ASCCP example prior, they often talk about ovarian and cervical cancer as if it's only pertaining to women. And I know that transgender men who have a cervix or are facing ovarian cancer will be hard-pressed to see themselves in these materials. So therefore, all components of comprehensive cancer care need to be reimagined to understand and accept differences between sex, gender, sexual orientation, and the diversity of people's lives to challenge who is visible and who is considered in these guidelines. We must ensure to move forward and to really help LGBT people that forms and processes reflect differences in experiences by LGBT people and their relationships to health and healthcare. This includes thinking about demographic differences, importantly, names and using correct pronouns, especially if somebody's gender expression seems to differ from their pronouns, medical history, medications, surgeries, including gender-affirming surgeries. For example, as I mentioned earlier, that many transgender men still have a uterus and cervix, and gender-affirming surgeries that people need to understand and learn about. For example, transgender women, most of the surgeries that are performed, if they're performed, do not remove the prostate. We also need to think about social support, family building, goals, and who might be a supportive partner during cancer care and treatment and throughout survivorship. We need to remember that some men have vaginas and to, well, get over it and be comprehensively prepared to take care of people as they come into our clinic, not just if we suspect that they are LGBTQ. For example, if you had Valentina Sampaio, who I understand is from Brazil, or Laith Ashley, two famous transgender models, walk into your clinic, you likely wouldn't immediately know that they were transgender and would need to ensure that your systems were able to care for them accurately and respectfully. So, in going forward, I want to give you 3 principles in LGBTQ plus care. The first is that LGBTQ plus people are different from cisgender and straight people. Having cervical cancer as a man is likely a different experience than having it as a woman. But LGBTQ people are the same as cisgender and straight people. If you have a part, for example, cervix, it needs to be screened, whether you're a woman or a man. If you have a rash on your arm, it likely doesn't matter whether you're a man or a woman or have an experience of being transgender. And then finally, LGBTQ people are different from one another. We cannot say, I've taken care of one transgender woman with cancer, I know how to take care of them all. Otherwise, medical training could be done by robots and it wouldn't take so long. And we wouldn't call ongoing clinical care medical practice. So in summing things up, I want you to think about your particular practice and ask yourself, what happens when somebody comes in the door? If a transgender man with ovarian cancer came to your practice setting, would he be welcomed, greeted appropriately with the correct name and pronouns used, and routed to the right care provider? And then what happens next behind closed doors? If you're a clinical care provider, do you know the questions to ask to do a comprehensive physical and to understand people's actual history of coming before they came to you? And then what happens between doors? If you need to refer on to a radiologist or somebody who provides chemotherapy, do they know how to work with and respectfully care for transgender or LGBT people? And finally, what makes your setting a destination of choice for LGBT people? In other words, what are you doing to open the doors? One thing that you can think about in moving forward is just asking yourself this question: how are you working to ensure visibility of all LGBTQ people? Are you asking all of your patients and research participants about their sexual orientation, gender identity, and sex assigned at birth, and carrying that through clinical and research and administrative encounters? As members of your local communities, what are you doing to make sure it is safe for people to disclose their identities to you and to people in their lives? So finally, it's not about more time, but more visibility. Bringing in sexual orientation and gender identity into educational and clinical interactions is just part of taking care of the whole person. And that's part of understanding the medicine associated with transgender-specific medicine, but also LGBTQ people. And this starts with our own training as providers, and then looking structurally at things like intake forms, electronic medical record systems, billing, and guidelines, and political advocacy to make sure that people are safe in all aspects of their life. One of the essential qualities, after all, of a clinician is an interest in humanity, and for the secret of care of the patient is in caring for the patient. Thank you so much for your kind attention. There are references with these slides, and then of course, please feel free to reach out with any questions.